meeting. This is the first meeting as myself as chair. I've been vice chair for some years now. Are the chair. And my first thing I would like to do is to publicly thank John Nicholson, who's now the vice chair, for 6 years of fantastic service as the chair.
Thank you, Michael.
Of that, and in the great honour, I think, can we just give an applause to that? Thank you. One of the things that I sent members around about the from the Centre of Governance and Scrutiny, March 2003 paper. One of the things it emphasised was the importance of the scrutiny being the voice. So one of the things that I suppose my theme as the chair is getting much more the voice of the service user, the patients, the families, the carers, actually much more available at future meetings. So the agendas might, I'm looking at the agendas for future meetings, hopefully be less of that, perhaps looking more at the briefing meetings on certain items, and deep diving on some of the issues that are actually quite important, and particularly important to residents' islands. So as you can see, we've got a big agenda tonight. It's quite big, and it's probably we can only spend about 10 minutes on each item, and some items we'd like to spend more time. So I'm going to look at that in future. So I'll formally open the meeting. Apologies. We had apologies from Rodney Downer, but Claire Critcherson substituted. So welcome, Claire. We haven't had any apologies. Oh, and apologies from Chris Hawkin from Health Watch. No others. Minutes. You've all had a copy of the minutes. Do I have a proposer for the minutes? Councillor Robertson. Can I have a seconder? Councillor Nicholson. Those to approve the minutes, can I have a show of hands? Any abstentions? I'll put my hand up as well. So, past the minutes, I'll sign here. Declarations of interest. Anything particularly on the agenda that anyone has a particular interest in? No. I would just, I always do this. I always declare that I'm a trustee of the Isle of Wight Youth Trust, especially if anything comes up about young people. I'll just declare that. Okay. Sorry. Any fire drills during this meeting, they are real and not practice. So follow the exits and don't use the lift. Thank you. Public questions. Have we got any public questions? There seems to be no one in the gallery. Nope. Okay, we'll move on. 5, outcomes, recommendations arising from previous meetings. If you look at page pages 9 and 10. We have from the previous meetings, dentistry on the Isle of Wight. I'm proposing that we particularly have dentistry on the agenda in September. And I know that Joanna, perhaps you could say something about the meeting you've been invited to at government level.
Bless you, thank you. So we are going to highlight particular issues on the islands. We know it's a national issue, but access problems are worse for island residents, so we know that. And we're going to highlight that. So we've got an opportunity to talk to ministers, which is really, really good. And it's really heartening that they're identifying that there are particular issues in coastal areas. So they're looking at that in particular. And they're also interested in problems pregnant women have in accessing dentistry, disabled people, and also in children. And given the fact that we've got a very high percentage of children on the island that haven't seen an NHS dentist within the past 12 months, you know, that's particularly relevant. I think in the year up to June 22, only 36 or 37% of children on the island had seen an NHS dentist within the previous 12 months. And that's almost 10% below the national average. So we've got a particular issue with children accessing dentistry on the island. So we're particularly keen on highlighting that. Again, because we've got significantly worse outcomes for our kids than other places, certainly within Hampshire and the Isle of Wight.
Thank you for that. Good, as we're going to have it on the agenda at the September meeting, that you report back, because obviously, because you mentioned children's, could we make a reference to the Policy and Scrutiny Committee of Children, so that there's cross discussion regarding this issue. Hampshire and Community Mental Health Services review. Well, this was sent this morning to this meeting, and also looking at highlighting mental health at the meeting in December. Winter pressures. I was going to, we were waiting something back from yourself, Laura, but I was going to suggest that we perhaps put that at the September meeting, because that's probably more relevant. I think it came out of last year when obviously you went through incredible pressures. So we had it on our March meeting, but I think what we said was it'd be good to talk about winter pressures before those winter pressures. In agreement with that, Michelle, as well, that we put that to September meeting?
I wonder if I may, Chairman, I'm not sure that it is actually an action that should be allocated to me. Local authority receive a significantly smaller proportion of the Wintershire funding than goes to the ICB. And I know that our colleagues at the Integrated Care Board have been undertaking a extensive piece of work in terms of financial planning for Wintershire. Whilst I'm more than happy to provide additional input from local authority, so far as we're aware, there is zero winter funding available to the Isle of Wight Council moving forward. So it would be a very short agenda item if allocated.
Yes. I apologise, Laura. I was given your name as the person linked to this item. Obviously, it wasn't. So, correcting that. Is there anything else that other members want to raise? No? We'll move on. Going to do item 6 now, but just after item 6, Simon, who's got to catch a boat, has asked me to move item 10. So we'll do 6 and then 10 and then 7. So on items 111 service, you've got a report. Are you here, Victoria, to talk about 111? Do you want to add anything to your report? I don't expect you to. That's it.
It takes a while to warm up.
Red's good. Red is good. Sorry, that's me. So thank you very much. Apologies for being late. I'm on call for the ambulance service today, so I've been dealing with a few things. You've all got the report in front of you, and I don't have much more to add apart from the fact that 111 service on the Isle of Wight has always been very well received by our public. We are one of the higher users per 1,000 in the country. So when you look at the numbers of populations per 100 and compare the island to other parts of the country, when the rest of the country was thinking about think 111 first, the island was already thinking about using 111 first. So during the course of the pandemic, we have reiterated that, and we did quite a big campaign along with NHS England to encourage members of the public to use 111. But actually on the island, there's always been a very good take up. What we're now seeing is we're starting to get an increase in the 111 online and starting to use that, which is a good. So that's probably not reflected in the presentation, but yes, you've all had that. I'm sure you read it. If there's anything you answer any questions on, more than happy to do.
Thank you. Questions? Councillor Robinson.
Thank you very much. Obviously, awareness of a service that's there to be used is a very good thing. But I'm just looking at these figures, just conscious here. Proportion of calls where the caller was booked into the GP service seems to be unusually high on the island as compared to nationally. And I just wonder whether there's an issue there that 111 is being used in some cases as an alternative to contacting a GP, and that's increasing the number of or whether that's whether that's a positive, a negative, or neutral.
I'll let Michelle come in a sec. I mean, my view, and Michelle might have a different view, is that there's always been a disposition on 111, which is GP. So you will ring 111, you'll be triaged, and you may end up with a GP primary care disposition. That's always been there. What we did, and we worked very closely with our primary care colleagues, is that it's very frustrating in the service if the disposition is GP, and then you say to the caller, "Bye, you need to now ring your GP," when actually what we worked to do was to connect to our GP practices so that we could do that. So I think it's a reflection of the way that the island healthcare works, that you can enact some of these things in a far easier way than if you have multiple CCGs, or what would have been CCGs and healthcare providers and 111 services and ambulance. It's just been easier to enact here. But Michelle, I don't know if you've got any else you want to say.
Thank you. I'm very glad to say I do agree with you. So for many years, 111 has been promoted as that's where patients go first. Then, as my colleagues kindly said, there is a disposition to booking with the GP. And what we've done over the last couple of years are there, in practices, direct appointments held for 111 to book into. I think the high numbers reflect the fact that lots of people use 111, and we've promoted that. And that was our strategy at least probably 8 years ago, that actually we would very much promote 111 first. And so therefore you will get a high number of calls, and then a higher number of calls being diverted to general practice. I wonder if you were sort of thinking about GP access, is that a reflection that they're using 111 instead?
Yes, I suppose it's the percentages, 79, well, I'd say 80% March 2023 doesn't mean much to me, as a lay person. But then when I look at the national figure and it's 54%, then that looks sort of, remarkable. And I was just trying to ascertain whether that's because people are calling, or people are clearly calling 111 more often on the island for a GP service than nationally, and whether that presents any challenges or problem, or any sort of burdening of the system with people using a service or a phone number for something when they could be contacting their local GP.
I don't think it actually quite works like that. I think they are contacting one first, and that's what we want to do. And then they're diverted, if appropriate, to GP services. So I don't think it is a reflection on that particular aspect. Would you agree?
Absolutely, and I think actually our colleagues nationally would want these figures. I think it's a really good thing for the island, and I think it's something we should be celebrating. Our strapline in our ambulance strategy has always been the right person, right place, right time, and the whole thing about actually as a system that could easily get overloaded, and that could be the ED, that could be primary care. If the patients are being funneled to 111, they will be triaged to where they need to be. So, we will book patients into ED, we'll book patients into UTC, we'll book patients into primary care.
John, your hand up next.
Thank you, Chairman. Just following on from Councillor Robertson, with the 111 service, if you've got somebody that's in a distressed state and they're relying on a phone call back, and I'm talking about a real life case, then might not be in a fit state to receive that phone call or notice that phone call. And then that might then lead to a visit to A&E, so overburdening the A&E. So how would you approach that sort of issue?
And obviously, I think we've spoken before about some of your experiences, and it's great for me to reply, this is how it should be, because quite obviously it doesn't always work in that way. But the ideal, we have clinicians in the 111 service. There's also the CAS service, so we're linked through to one of the GP practices, Tower House, and then out of hours, there's a contract with a GP advisory service out of hours, PHL. During the day, if it's like during the day, we've got the clinicians, and if your disposition is such that you have rung 111, but actually on that clinical triage, your disposition, it may be that you are an ambulance disposition. So there is an ability to do what's called a warm transfer from 1s to 9s that enables that transfer of care into the 999 service, so that you then become under the ambulance service. That doesn't happen on every occasion, because there may be it's the callback. But what you're saying is, if you get a callback and you live on your own, for example, you might not be able to answer the phone. And I think they will try a certain amount of times, and if that person doesn't answer the phone, it should be a transfer into the 9s service. So it's meant to be a seamless sort of pathway.
was really whether the person might not be in a fit state. Notice the phone is ringing. Kevin, is it all right if I ask under this question the liaison police, who are often first responders to people, and given the national news on the police in other locations to be involved in health matters, are we finding that on the island?
So anecdotally, we work. I mean, we're not finding that. We work very closely with the police, and I have a quarterly meeting with my blue lights colleagues, so ambulance, police, fire. So there is a strength in the relationship. However, the control rooms do speak to each other. So if my crews go out there and there's a patient who quite clearly isn't a patient yet, but they've got some, and they'll do something called a dynamic risk assessment. And if they feel that there is a concern for their own welfare that they can't manage, then we will contact the police and it will go through their control room. So we've tried to create a system where the police don't feel that we're abusing them unnecessarily by calling them out to things that are what they don't see as their police business. But what we do is we'll do a dynamic risk assessment, and then if we feel that the police are required, we'll go through their control room, and they're pretty responsive.
Could I say that it's reassuring for the committee to hear that, but could we have some sort of press release so the public can also be reassured about giving national news service?
That's something I can take and speak to my colleague in the police, because I think they should be the agency that is reassuring the public about their activities.
I think that there's one or two items, I think, tonight where obviously there's things going on nationally, and reality is the public pick that up. It's in the national news, and you immediately think, is that going to happen in my patch? So I think there is a need to often put out comms to say, actually, this is what is actually happening here, to reassure, because we have a lot of residents who rely very heavily on that little box. It's quite a big box now in the corner, regarding that. So if you could take that on board, that would be
absolutely, and maybe we can
good.
do that across the blue lights.
Yeah,
we work very closely with fire, police, strength in
Councillor Lever.
Thank you, Chair. We were discussing prior to this meeting about the calls answered and abandoned. But firstly, I guess I was just wondering if we have any sort of data on the reasons for abandonment. I mean, I'm not sure we do follow-ups to understand those reasons, but at least a split of abandoned before or after the call has been answered might give us an indication on whether it's the wait time that's causing that, perhaps. And then secondly as well, I'm just a little bit concerned of the calls abandoned, we're frequently above the national average, and especially when it hits December. Are we learning from that in future? So obviously when December comes around next time, have we got any plans to address perhaps that peak?
So yeah, really good spot on all of that. What you've got is 6 months worth of data. What you haven't got is 18 months or 2 years worth of data. And what you haven't got that correlates under that is some of that narrative along things like staffing. So we are a small service. We're a resilient service, and we're a very stable service, and we have been for a long time. But during COVID, we did have to increase the number of call handlers quite significantly, and we had some of the biggest recruitment drives that we've had on the island for a long time. Really good for the island, brilliant for the island, and it takes a period of time to train people. So what we found during COVID is that we recruited quite easily, and I think that was partly because there was a number of people on furlough, or there were people that were losing jobs maybe. At the time, we were only putting out fixed term contracts because we didn't know that the funding was, nobody knew what was happening in COVID and we didn't know what was. So cut a long story short, we saw quite high turnover, which is really unusual on the island. And I think there were some people that were probably coming in and they came into an incredibly busy service. Our staff who've been here for a while, it's almost like the busyness has crept up with them. And when busyness creeps up with you, you manage busy so much easier, so much better. So we saw sickness levels for things like mental health issues, stress, significantly high. So we've perpetually been trying to catch up, and that period that you've got there where we're not performing as well against the national is really unusual for the island. Our call answering times are some of the best in the country, and we're really proud of that here. And actually, if you start looking at our call answering times across April and May, we're back up there because we've done the recruitment. So I'm not worried going into winter. I just think we've gone through a period of change, and actually we've got stability back with the staff, and we've got full complement of staff, which is the first time in a while, so it's good.
Michelle, you wanted to?
Yes, just to add, the data that you refer to, Councillor, is in December when we had the Strep A outbreak, which was a national problem but magnified on the island. At times we had the highest instance of Strep A. It was unprecedented demand on all our services, but particularly 111. It was just something that I don't think many of us have experienced before. So that will also refer to the data that you rightly point out as well.
But I can't answer your question, just thinking about it, I can't answer your question here and now around the splits, because that's a really good thing. Is it people abandoning it before we answer, or is it we've answered, and then for some reason they've decided to hang up the phone? We'll have that data, and it's certainly something that we can share.
Is it possible, sorry, I'll come back to you, Councillor Robin. Is it possible that we let us have that data? And also, because you've got sort of good news of the following data, right? It'd be good to have that as well. That would be useful.
Yeah, to see the story. So yeah, I'll speak to the PIDS team. I'm pretty sure they can get the data. I'll double check first that they can get that split, and then I'll confirm it. And if we can, we'll share it.
And we'll circulate it to them. Councillor.
Thank you, Chair. The table I'm reading on proportion of calls abandoned have got worse since December, so this year, compared to the national average. January, February and March, proportion of calls abandoned on the Isle of Wight were well above the national average, which wasn't the case towards the end of last year.
The Strep A was December, January, so that bit where we were, yeah, so we went against. It's the same narrative. We didn't have the full complement of staff. So, and nationally, most 111 services were siphoning their calls out to other providers where contracts had been set up because they didn't have the staff either. So we hadn't called on as an island. We hadn't pushed calls off island in terms of getting that clinical. So I think my answer is the same. The calls being abandoned was as a direct correlation of the fact that we didn't have the complement of staffing levels, and we've now got those, so we're seeing that trend shift. So you'd be better off looking at the April and May and see where we are now.
Okay, Councillor Christensen.
Thank you, Chair. I was just saying, actually, with that, bearing in mind those statistics and that we are looking at the demand and capacity of that service, is it still as effective as it was? Is it still a really good tool for the public to embrace and keep using, and that we're happy with the figures we've got?
Absolutely. Yeah.
I'll second that.
Good. Thank you. I think we've covered that. Thank you very much for coming, Victoria. And thank you for all the good work you and your team do. Thank you. We're now going to item 10, which is mental health and suicide prevention update. You have had a full report that was put forward. I will say at this point to the committee that I'm proposing that in our December meeting, we actually have a full agenda item about mental health, because it is a priority of Health Watch and it's been a priority of this committee. But I do welcome this particular strategy and report. Over to you, Simon.
I've got a couple of colleagues online. I've got James Seward and Sue Cochrane, who are going to go through the detail. I think what we've seen, excuse me, most recently on the island over the past year is bringing together what we call mental health, which is actually talking about the mental illness services led by colleagues in the ICS and the Trust, under Leslie Stevens. I know she was trying to get here. She's on her way. And also the mental health and wellbeing and suicide prevention. I think what we've really done is brought those together, because that's really important. Often the language we use doesn't help us think about both those aspects. So you've got a fairly full report here. I think we need to be really clear, very happy for more detail back in December, what we want from that. Because I think this report really sets out what we're doing, the achievements we've made, and the kind of work going forward. So I'll hand over, I think I'm handing over to Sue first of all, and then it's over to James.
Thank
So-
you.
so-
Hiya. Yes, I can hear you. Can you hear me? I hope you can. There's a bit of a delay, I think, between you and me, but we'll work with that. I've got some slides, if that's okay to share them, but they were in the pack. So just let me know if you don't want me to share them. If not, they should appear on screen in a moment.
So they're quite small. We've all got them in the pack. So you just
Have you?
Yeah, just want to talk through them.
Sure. I'll stop sharing if they're not
Well, that's just
useful.
to
Good.
talk through. We've got all the packs, so you don't need the slides. Thank
Oh,
you.
wonderful. Thank you. And sorry if I'm talking over you. There is a bit of a delay, so I'm kind of just going for it. So James and I are both here to do a bit of a double act, because as Simon said, we've done a lot of work over the last few months and really post-COVID to bring together the work that's happening around mental wellbeing and mental health services, and really tying in our work around suicide prevention within that. And the result of that is that we have an island mental wellbeing plan for the next 5 years. And we worked with the LGA sector-led improvement process to really get us to the right place in terms of that being a true representation of our partnership plan. And woven into that is our suicide prevention priority, which underneath which sits its own action plan. And that's the bits that I will go through, and I'll then hand over to James, who will talk about some of the work happening from a mental health services transformation perspective. But we absolutely are working together in terms of really thinking about that spectrum, starting in the prevention and early intervention space and moving forward through into when people need services, that they're the right services and that they're available for them. So you'll see in the slide pack, we've articulated some of what mental wellbeing looks like on the island, and the first slide goes through how complex the picture that really is. So the first thing that it shows is that within around COVID-19 we saw particular vulnerability about mental health within our urban areas. So we know that people in our urban areas are more likely to be vulnerable to poor mental health, mostly because there was a younger demographic who was really impacted by some of the lockdown measures, but also some of that aligning with deprivation, which we know is a risk factor for poor mental health outcomes. But then since then, we've got some really good data coming out through our joint strategic need assessment that shows that when we look at, for example, where risk factors for older people and social isolation sits on the island, that's potentially in a different place. So we're looking at Shanklin, Newport and Ventnor, and it is quite a complex picture as to where we need to focus our efforts for the island. And that has really helped informed us to think about what approach we want to take, absolutely bringing everybody with us. We've all got mental health and wellbeing. We all need to think about how we talk about mental wellbeing and how we ensure that we protect our own and others' mental wellbeing. But we do need a targeted approach, not just in geographic areas, but also for some vulnerable population groups that we know exist on the island and we know are potentially vulnerable to poorer mental health outcomes, such as people with substance misuse issues and previous exposure to trauma. So the work that we've been doing within public health is absolutely in partnership with other agencies to improve mental wellbeing and prevent suicides. And one of the key mechanisms that we've got to deliver that is our Mental Health Alliance, which has grown from strength to strength. We're really proud of the work the Mental Health Alliance does. We have now over 40 organisations across the island working on mental wellbeing, coming together regularly, thinking about how we connect, thinking about how we can work together more effectively. And we recently ran a workshop to really shape what that work programme is going to look like to deliver the plan over the next few months, aligned to the mental wellbeing plan. And we used the Alliance in 2021 to ask people what they thought about what were the negative and positive drivers for their mental wellbeing. And that again is in the slide set. We really did identify that people that people have worries about family, work, loneliness, not sleeping, but actually the island has a lot of assets that are positive and protective factors for mental wellbeing that we need to work together to really capitalise on. And that where people go for support includes primary care, but actually kind of running up right behind it are family and friends, and we need to think about how we use those positive networks on the island to promote mental wellbeing. So the slide pack shows our commitment that we've worked across the Mental Health and Suicide Prevention Partnership with the Local Government Association sector-led improvement process to absolutely gain commitment to partnership working for mental wellbeing across the island. We have it signed up by a number of different organisations, and an absolute commitment to working around the prevention of mental ill health, around enabling people to know where to go if and when they need support, and thinking about those wider determinants, knowing that, for example, if you're insecurely housed, you're absolutely at risk of poor mental health outcomes if you have secure housing. And the same could be said for other wider determinants, such as what job or employment opportunities you may feel like you have. So the slide pack again then goes through into our agreed priorities. Number one is absolutely working on this partnership approach that I've said, and we'll continue to reiterate that it's all of our business and we keep working on that guise, but actually really focusing down on things like community resilience, thinking about those assets that are on the island and how we can use them more effectively. Absolutely being the pioneers of positive use of language around mental wellbeing. We all own it, and it's all our responsibility to use the right words, to talk about our own mental wellbeing, to use the words around suicide prevention, and to upskill ourselves. We're doing lots of work on wider workforce development, particularly around suicide prevention, and again to think about those wider determinants of health. So there's a slide on there that shows our areas for action, and it's absolutely not a standing start, but going into depth around the suicide prevention plan, which was the update that I was specifically asked to bring to today's meeting. We have 7 priorities that we're now focusing on around suicide prevention for the island, and those, if you have the slide set in front of you, are on slide 6. And the work that sits behind these, so the first one around increasing awareness and understanding of the wider determinants of health. I've mentioned already that we're rolling out suicide prevention and mental wellbeing training to the wider workforce. We have absolute commitment to carry on in that space to ensure that we're providing training around suicide first aid, around mental health first aid, and around money and mental health, because we know that debt and anxiety, particularly as the cost of living pressures are absolutely acute for people, need to be talked about together. So we're providing training on that for the island, and we're also working with James and his colleagues around developing pathways for people who have co-occurring mental health and substance misuse issues, knowing as well that both of those are predicators for suicide risk. The second priorities around tailoring approaches to suicide prevention. So that work is around incorporating mental health and suicide prevention into work, for example, on domestic abuse, on substance misuse, as I've already mentioned, and on ensuring that we've got things like a real-time surveillance system in place to help us to look at suspected suicide data in a real-time way, and look at trends in a more nuanced way than we currently have been. And other work that's covered by the areas for action include partnership working with the Coast Guard around reduced access to means. So in the past, we've worked both with the Coast Guard and the National Trust around signage on the cliffs, and there's more work planned in that space. But we absolutely know that there's evidence base behind supporting work with those partners, and we await the National Suicide Prevention Strategy, which we think will come out with some signs around some online harms, with online harm bill that's also expected nationally. So there's been really good news on the island in terms of suicide prevention.
Sorry, it's absolutely great, and thank you for the report. We've actually got, I mean, everybody's had a copy of this, and all the members have assured me before the meeting that they had taken it all in. So can I just stop you there, because I'm really conscious of the time of the meeting.
Of course.
And whether if James was going to just add to that, and then we can open it up for questions. Is that okay?
Yeah, of course. Over to
Thank you.
James.
James?
Hi, good evening, everyone. Yeah, just really quickly then, in terms of our part of the equation of working with Sue and her colleagues, our priorities for the coming year and recent months have been to continue to implement the mental health strategy, the No Wrong Door strategy. We've made really good progress around those areas, and we need to consolidate the development of that, particularly as we move into our partnership areas. And to complement the strategy, we've got a set of priorities which are from the health side about looking at improving locality development, of integrating and mental health and wellbeing service with physical healthcare conditions, so that we can offer more joined up services closer to where people live, so that we can offer support to people who have got both mental health issues and physical healthcare support. We're continuing to work with partners on the implementation of dementia strategy and how that relates to older people with mental health needs, where there's co-occurring conditions there as well. Improvement around CAM services, children and adolescent mental health services, with a particular emphasis on people that transition between CAM services and adult services, and the fact that we need to do more to support the particular needs of people that are moving through services in that kind of way. There's a big focus on doing more work around people with autism and ADHD, or which neurodiversity issues that we need to work on. Improvements around acute services, which are our inpatient services, and really trying to harness the benefits and working in partnership with our mainland partners to provide a better offer around inpatient care, and to make sure that we prevent and get in the early intervention part of it, which is really important, with working with our partners to do so in terms of that avoidance of people moving into crisis, the escalation of their conditions, issues around suicidal ideation, which Sue's already touched on, and making sure that we can prevent as far as possible in that area. And the final bit of our priorities there are around, and something that I'm particularly proud of that we've made progress with, is really walking the walk about making sure that we co-deliver and co-produce the leadership of our services with people with lived experience, which are now embedded in the trust services at leadership level, but within every service cluster that we've developed, we've now got lived experience leads as part of that leadership team. Final bit from me, Chair, is about just to confirm that we've, in partnership with Sue and others, we've just launched a mental health learning disabilities transformation board for the island, which is a stakeholder group to bring together all the statutory partners, but also with the voluntary sector, to focus on NHS commissioned services and how we can optimise the way that we work together to improve those key pathways that I've just identified there. It's early days for that. That board was launched in April this year, but I think the sense from our partners, certainly third sector, was that this was the first time since COVID that we'd already got in a room and tried to work together to improve the way in which we deliver pathways to services and try to get the benefit of working together more effectively there. So what Sue and I have tried to do is to make sure that we've brought that in stream and aligned it up with the governance processes that we've got already with the Suicide Prevention Partnership and other entities like Scrutiny Committee, and as part of our Health and Care Partnership moving forward, which is in the papers there as well. So that's probably more than enough from me too, Chair. So I'll probably pause at that point and hand it back to you for any questions for Sue and I. Thank you.
Comprehensive. As I actually stated at the beginning of this item, we are looking at December's meeting where we can actually deep dive a bit, and that will give you time with some of the things, James, that you've said, because I think the music to our ears on this committee was actually you're working effectively together, because I think in the past that's not necessarily always been the case. So it's actually good. And I will make a comment. I think the two comments was particularly with the suicide strategy, we had an input from the LGA, the Local Government Association, someone called Steve Bedster from Birmingham came involved and actually gave the sort of thumbs up to the work that's actually been done. So it was actually very good from another area to actually say on that, and that's why we involved the LGA. So it was quite good. And the other particular point, which is music to my ears, is the amount of the 40 organisations involved in the Mental Health Alliance, which is very much stimulated by the grant funds that Public Health set up, which has been very successful and has actually got those groups like veterans, groups in localities around the island and a lot of communities of interest in place. And so one of my questions particularly to Simon, is can we make sure that grant fund is now built into the budget and is actually part of our mental health strategy? Because you wouldn't have had the real growth and the fantastic work that's been done in this report without the involvement of those groups that we stimulated through that grant fund.
Very happy to pick that up. So yes, we can look at the grants. I think what we need to do is make sure the money we're using is effectively used. And I think one of the challenges of giving small grants out for one-off, which is what they are for, is how you evaluate that. So that's a bit of work. I think it's probably really important, as you say. What they have done is worked with local community-based groups to think about mental health. And the first year was focused on adult mental health, and there's one on kind of cost of living. So we just need to think about how that works with our partners to make sure that we really embed the learning from those going forward. But very happy to look at that.
Questions, Joe? Got your hands straight up, then John.
Thank you, Chair. Yeah, thank you both. It's really good to see the strategy it's very broad, so it's good that we're taking a holistic approach. I think regarding the priority outcomes, it's nice to see now the plan unfolding what we will do and how we're going to get there. I assume it'll be for the December meeting that we'll start to see the detail of that, because my next questions now are how we know we'll get there. It sounds great, but I'd kind of want to understand targets and timeframes about how we see that unfold and making sure that we can actually scrutinise the performance on that.
Do you want me to answer that one? Yes,
So
we'll bring that.
Hang on, so Michelle, pick it up.
Oh, fine.
I may not definitely pick that up, but I'll try. Okay. So my question was, or my point was that in December, maybe we could focus on one or two things, because otherwise I think it's such a, as you already said, very broad. And I was wondering if you would think it was appropriate, Chair, that we could get some of those organisations that you mentioned to come along and present to us, widening, our information. I think that would be really nice to hear them come along, and it may not be quite the deep dive that you wanted to do, but I would really value their feedback.
Shall I? So I know it's quite hard online. So I think one of the things we need to do, we've got a really good plan, as you say. Measuring it is, mental health is, well, mental illness, we measure episodes of care. That's not mental well-being. We measure suicide. That's not what mental well-being. It's quite hard to measure mental well-being in the same way that we measure smoking, coronary heart disease. So we just need to think carefully about that. But there's an awful lot of good work. And as Michelle said, I think it'd be helpful to bring those organisations to show what they're doing, which then demonstrates the action. And we know that if it's evidence-based, it will have a difference to our mental health and well-being.
Yeah, sorry, Chair. Can I just, I think all I'm getting at is because how we know we'll get there, there's points like increased awareness of support available. How do we know we've understanding that we have increased it and that we've hit that target, and by how much and things like that?
Yeah, we can look at measures like knowledge. We can look at the happiness score. So there's a number of things we can do, but that doesn't necessarily measure, as we were saying, mental well-being. But yeah, absolutely happy to look at that.
I think if we in December have actual representatives of some of the groups that are part of this, their story, their journey will actually help us with some of that information. Any further questions? John, you had a question.
Thank you, Chairman. Yes, I mean, it's very encouraging to see this. And of course, if it's a live document, then it's going to be continually amended. And I thought it might be helpful in the glossary to define exactly who partners are and clients, and as mental health applies to everybody, who the rest of the people are. It talks about the actively informed environment. I'd like to know what that is as well, please. And there seems to be no mention of or definition for adverse childhood experiences, which, as we know, play a significant detrimental effect to mental health. And you refer to the NICE mental health well-being at work, but there's no reference to ISO 45003, which is managing psychological risk at work. Is a significant document and regarded by all good companies. So you might want to make use of that, particularly in the workplace. And as Simon knows, I'm a big fan of the chimp paradox and what Steve Peters says, and I do think the language in that and the model in that is really easy to understand and helpful to anybody trying to understand the complexity of the mind and different states that we get ourselves in. That's it, Chairman.
Thank you. Any other questions? No. Sorry, I just wanted to, I think James brought up about dementia and in recent talks with Laura Gordian, Director of Adult Social Care. I think it would be useful to put that on our September meeting as an item. I know that we've now got the dementia strategy in place, but it would actually, I think, be quite a good opportunity early on to actually to sort of look how that is actually going in place. So I was going to put that on. So I'm glad you picked that up, James. Anything else? No, we'll move on. Thank you. We're now back on to 7, adult social care, public health, ICBD, health and NHS budget. When I looked at this item, it is a huge one and there are huge issues, obviously, on budgets. And obviously, you've got the emerging new organisations. So one of the things that I was suggesting to committee from the chair is that we collaborate with the audit committee, and I have spoken to the chair of audit because this is that crosses over audit and this committee, to actually look at a private briefing with all the partners to actually have a discussion about this issue, the crossovers on budgets, and obviously the issues of deficits, which sort of goes with the subject now, and side, because it is a big subject and I think we need to seriously look at it. So I was going to overall suggest that we establish a meeting with all the partners and committee members in one of our sort of informal briefings, right, where we can probably dig down deeper on some of the issues, and to do that in collaboration with the audit committee. Everyone is in support of that from the committee. But if we've got particular questions at this particular time, are you willing to answer some of those? Got particular questions? I've got one from Councillor Nick. What's your question?
Yeah, I mean, we understand that forming the Integrated Care Board is a mammoth task and involves a lot of a lot of bureaucracy. How are the proposed redundancies across the ICB, Hampshire and Isle of Wight, going to affect performance?
To clarify, affect performance of the operating of the ICB, or right? So the ICB, like all health organisations, is going through a difficult period financially, and we are looking to meet the challenge set out in the NHS operating plan set by NHS England. That will inevitably mean a shrinking of our workforce size. That does not inevitably mean a shrinking of our performance or our ability to commission the services that we need to for healthcare. It does mean that we will need to reorganise our workforce, and it does mean that we will have to think very carefully about how we meet our statutory and legal responsibilities and obligations, and we will continue to do that with a smaller workforce size.
The question really that I was asking is, the people that you're shedding, are they now, is their workload redundant? Was it necessary for the forming of the ICB, and it's no longer necessary?
So I think it would be remiss of me to suggest that the workload that they were carrying out was redundant or not necessary. We are reshaping the work that we carry out as an organisation. So some things we have been doing and will no longer do because they are not part of our statutory responsibilities. Some things we will deliver differently. It is not necessarily that the work we were doing before wasn't necessary, it's just we will do it differently in other ways. For example, the opportunities that we have to work across Hampshire and the Isle of Wight collectively and to collaborate across our entire organisational boundaries will allow us to do things once instead of 4 or 5 times over, and that creates efficiencies.
Chairman, could I ask that the committee is kept informed of the progress there and given continuous assurance that the quality of delivery will not be adversely affected?
Yes.
Yeah, happy to do so.
Chair, just a point of clarity. Obviously, the audit committee has no ability to lawfully audit the funds or the financial arrangements of either the NHS Trust or the ICB. My understanding is what this committee is seeking is an informal briefing session that incorporates audit committee colleagues as well. Just so that we're very clear in relation to the remit.
Absolutely, and I think that's why it's important to do it in partnership with the audit committee, because they, in a sense, have authority. Well, they don't have authority, but they have. It is part of their remit to actually look. Well, I disagree. I think that there's a side within that, but I'm happy to talk to you after the meeting regarding that.
I think, Chair, that might be an ideal opportunity to explore, because the Isle of Wight Council's audit committee is an internal committee. It has no governance.
I accept that, but I think there's a joint. There is a crossover. Thank you. Item 8, we're on to Isle of Wight Park strategic partnerships. I think one of the, again, I think probably for a future meeting, to get to a real understanding of how it all comes together. And one of the things I would request is, could we have a diagram, a sort of organisational diagram or matrix, because it changes so often. I'm sure you get blurred, but I definitely get blurred by it. And I know the rest of the committee have the same issue on this. So if we could actually have a diagram, and so we can actually understand how all these players interact.
Actually,
John,
Chair.
did you want to raise something at that point?
Yeah, under this item, very interested to see Darren Cattell's new position as Director of Place for the ICB. What exactly does that mean, and what will his duties be?
So, as you'll see from my title, I'm currently the acting place director. Darren will relieve me of my duties in mid-July. For the ICB, that means that Darren will be the senior figure on Island, acting as director of commissioning of health services for the Isle of Wight. So previously that would have been a managing director. It's now called place director, and it's to work in partnership with all health providers and social care providers across the island to help form and direct strategy and to direct the health resources that we have available.
So is it just a change of name?
No, it's not just a change of name. It genuinely is a change of focus of the role. So this is about bringing partnership and strategy together. It's about collaborating with all of the providers on Island and ensuring that we plan effectively for the future well-being and health of our population.
Sounds fantastic. I think the key is it would be good to have a plan to see how that actually links, and also we as a committee are talking to the right people about the right things.
So the Isle of Wight, the Hampshire and Isle of Wight ICB strategy is just about to be published in the form of a joint forward plan, which really happy to bring back to a future meeting, and we can talk about what that contains. But there are a number of threads through that plan in terms of the strategy for the next 2 to 5 years. I'm sure Darren would be happy to come and present on that at a future meeting.
Is there anything you want to say from your side about in relation to the update?
Yes, absolutely, Chair. Thank you. I'll just do the update on the health and care partnership, and I should say at the beginning, Nikki Turner kindly sent me a diagram which you were referring to a few weeks ago with structures. However, I've been on holiday, took my elderly father on a cruise, and so I didn't get round to getting it in the papers today, but I can provide that next time for you. If I just give a quick update on the health and care partnership for the Isle of Wight. We're following the structure that exists across Hampshire and the Isle of Wight. So Hampshire and the Isle of Wight Integrated Care Board consists of a partnership board, which has quite a wide membership, and a smaller functional board, which does more of the executive work. And we're doing that on the island as well. So why we are very keen on our Isle of Wight Health and Care Partnership Board is that it has a wider representative representing more people on the island. And then we have a much smaller group, which is an executive delivery group, which is undertaking delivery of those strategies, which we've talked about. So the sort of health and care plan, which we've brought to this committee many times. And the partnership will hold the executive board to account and make sure that those are being delivered. But actually, my view, and I think it's shared by members of the partnership, is that they are there to look at what's happening across our Hampshire and the Isle of Wight at the moment. So there are obviously like the acute partnership, which I know Nikki will talk about shortly, and fusion, and we need to be mindful of what that may mean for island residents, and that's what the partnership will be there to bring that under the spotlight and making sure that islanders are fully represented in that space. We're looking particularly at a prevention agenda, and we're looking very much, as we always have done, work very closely with our colleagues across the Isle of Wight, and particularly making sure that from your guys' point of view, the health and well-being agenda and strategy dovetails with us, so that we can make sure there's not duplication, but we're delivering that holistic approach for islanders. And next time I'll bring a diagram.
Sorry, Nikki, I hadn't pressed my button. Nikki, do you want to add to what Michelle has said?
I'm really happy to, and apologies if there's a bit of delay on the line. Certainly, just to follow on from what Michelle said, our working in partnership has been very strong on the island. It's very evident across Hampshire and the Isle of Wight that we are certainly leading the way in some elements. The maturity of some of our acute services partnership or our ambulance partnership as another example, again, is quite evident. And just a small amount of update around the acute side. In particular, you'd be aware that Penny Emirates is now appointed from the 1st of this month as the CEO, not only for Portsmouth, but also the CEO for the Isle of Wight NHS Trust, as Darren moved on to his other place role, as outlined by Natasha. What's really important in our next steps as we move closer together and work as a group of hospitals is the fact that we are looking at appointing into one executive team to support both organisations. But what's really important in that is as well is a very strong site leadership team. So the directors that you normally engage with and talk to are very evident, and some of those individuals might change and might choose to move into an executive role. The other key thing for moving our partnership forward is around clinical leadership across the 2 hospital sites, and that's probably the next steps in progressing how we can work together and deliver services. And I think that's a sort of theme, particularly from what I've heard from some of the presentations to get today, that collaboration not only on island, whether at neighbourhood or place, but also between specialist services like acute services, for example, and the ability to work across those boundaries. We know island services are very small, and we know that we actually have to work together, and we've got some great examples of where that's been successful. Stroke services is something I've mentioned before. You heard from Victoria earlier around the 111 service, but the 111 service is improved significantly, and that's because of the association of partnership with South Central Ambulance Service, in the fact that we were able to deliver and develop IT services with them, and actually we provide additional 111 support to SCAS as well, because we are able to develop teams on the island to do that. So there's lots of benefits in that space as well. So certainly the next couple of months are going to be busy around leadership for the acute trusts, and then looking forward to making sure that we're delivering our operating plans. And I know we didn't touch too much on the financial position, but we know the financial positions are significantly challenging across all our organisations, and actually the way that we can improve that position is doing things differently together. And I think that will be a key theme coming out and moving forward, and in particular how we keep our population, our local communities at home for longer. Home first is something you'll hear a lot more about going forward as well. I'll pause there if that's okay, Chair, but I'm happy to take any questions. But I'm mindful we've got Fusion update as well, which I'm assuming James will be doing, or Leslie if she's on the call.
Oh, sorry. I will quickly, Leslie, just do Fusion as well, then I'll open it for questions from members. If you could give us a brief. We've obviously had this very large document that you've sent over today, which is lots of things that you're doing or completed. So we don't need that repeated. So if you could just give a brief summary on the progress of Fusion, which is particularly the mental health and community health services. Thank you.
Yeah, thank you. So as a reminder, Project Fusion is the work to create a new community mental health and learning disability organisation that covers all of Hampshire and the Isle of Wight, and that will include the current community mental health and learning disability services delivered on the Isle of Wight. This is not expected to have an impact on our day-to-day delivery of community mental health or physical health services, but it will give us access via a specialist organisation to clinical specialists, to opportunities for training and development and recruitment of staff, along with various other benefits. The project is on track. We are going through a formal process, a transaction process with NHS England. They have reviewed our strategic case and have been very positive about it, actually, and are comfortable with us now progressing to develop a full business case, and the work to do that is in progress. We're right in the midst of due diligence and planning for day one of the organisation. The recruitment of the chair for the new organisation process is almost complete. We're expecting an announcement around that any day, and the chief exec recruitment will start very quickly, and we expect it to be completed by the end of July. Our particular focus is on engagement with our staff, the people who use our services, our partners, and right now that engagement is really focused on the organisational form, and within that I include the vision, the values and behaviours, what the priorities of the new organisation will be, but also the organisational structure and the leadership structure that will support that. And really crucially, the name of the new organisation is part of the current engagement. We're also, as you'll see in the slides, keeping people who use our services updated on a regular basis, and there have been recent letters that have gone out to everyone using our services.
Thank you. Just for everyone here, just to clarify, so everybody's understood, in the past, our mental health services on the island have been a department of the Isle of Wight Mental Health Trust, whereas other services on the mainland are under designated mental health trusts. So if I'm clarifying that Fusion or the eventual name for that mental health trust would be actually managing our mental health services. That's correct?
Yes, that's absolutely right. It will continue to do the really good integrated work that we do with our colleagues in ambulance and acute in our current organisation. There's no intention to row back on any of that, but that will come under the auspices of the Isle of Wight Integrated Health and Care Partnership. But from a trust perspective, we will in future be part of a different trust from the Isle of Wight Trust.
There'll be a rebranding of that. Yes? Thank you.
Yeah.
Just to point out to all of you, one of the things that I'm looking at is that this committee actually has a working relationship with the Portsmouth and area health scrutiny panel, and I have communicated already with the chair of that panel, which actually includes a number of Hampshire areas within it, because we're now going to be, in a sense, responsible for organisations like Portsmouth and Isle of Wight, the NHS Trust, obviously the ICB, and now on mental health, that will cross over our areas, right? So it's actually useful, right, to have those relationships and actually share agendas, and in some cases perhaps do some joint meetings together. We were also in communication with Southampton, who have a separate scrutiny panel within that. So we're looking at the strategic approach of working with others in regards to scrutiny, as well as you are as providers within that. Is there any specific questions to that update? Yes, Joe?
Thank you, Chair. I guess a similar point to the question I had on the mental health prevention update was, it's nice to know kind of, I guess, strategic updates, and there's a bit more context with the Project Fusion work, but I'm finding it difficult to scrutinise if we've not got specific targets, performance and timelines to understand with some of these things. And I guess some of the changes that are noted in here about what this new approach is going to give us, understanding from my point of view why we perceive those improvements to, why we perceive them to work, what's the rationale behind that.
So,
Michelle.
yeah, I just offer apologies really, because I've come to this committee for the last couple of years and given really in-depth updates and provided large packs of papers, and I think I just assumed tonight it would be just a verbal update just to sort of say where we're going, and particularly that we had our first meeting about a week ago, and so it was very exciting. But I can come back with a full set of data and targets and update you more formally and appropriately. I just, because I've been doing it for the last couple of years now, just did a more brief update, so apologies.
No, that's fine, Michelle. This is my first time on this committee, so I appreciate the probably was previous context, but yeah, thank you.
Particularly on the mental health, we got an opportunity in December as well. Any other questions? No? Anything you want to add? No? No, thank you very much. And thank you for the thing. Well, I have one question. Will the CEO be coming to this meeting from the Portsmouth and Isle of Wight trusts? She come to this meeting, or would it be someone else?
I'm not sure. I think that will be a decision for Penny and Nikki. I'm not sure whether the chief officer from the Isle of Wight Trust would be in attendance. I suspect it depends on the formalisation of the new arrangements of the executive structure. I'm sure there'll be a nominated.
That's absolutely correct. And I would expect the chief officer to be in attendance, but depending on what's on the agenda, we would, Penny might want to come, or others that are pertinent to the discussion. So we'll make sure that we've got the appropriate people with you.
And similarly for community mental health, the new chief exec, I'm sure, will want to engage with this overview and scrutiny committee. But we will always ensure that there's an appropriate person here.
I think the key message as an island, we've often felt perhaps overlooked. So we have perhaps a complex about that. So it's actually very good that we're past these new arrangements, that if we do want to speak to the heads of, we've got their availability. So that's important. Simon?
I think you're right, Chair. I think something about being really clear on the question we're asking, then we get actually the right person with the chief behind it. And I think that would really help this committee, as you're saying. So that would then help us move forward.
Thank you. Thank you for that. Sorry, I didn't have this on. I know, Laura, you've done a very good briefing already to members, and I know that you're going to do one in July, further one in July within this, and obviously everyone, I'm sure, has read your report. So, haven't you? Yes. Right. So, over to you.
Thank you, Chairman. I'm not going to go into the report in any detail at all. Suffice it to say, it is what it is. Adult social care will be subject to formal assurance, not inspection, from the Care Quality Commission moving forward. We're still waiting to find out what that actually looked like. There's a number of pilots that are in place. I had the benefit of being able to brief Cabinet on Thursday last week. An open session to all councillors on Friday resulted in a very limited attendance, but the councillors who were there were engaged, and I'm pleased to hear all of the information I had to share. The session in July, I'm not clear on, Chairman, so I will go back and check my diary. I'm not aware of any further sessions that are arranged, but I am happy to share with all councillors any additional information that they require in relation to the process. What I would say and caveat that offer is that
The report currently contains all of the information that's available to me. The information is slowly being drip thread through to local authorities and will in a large part be shaped by those 5 pilot assurance visits and then the 25 that follow based on the CQC's assessment of risk in relation to those local authorities. I can confirm at this stage the CQC have indicated that inspections will be announced, unlike Ofsted inspections for colleagues and children's services, and we've not been advised that we are part of the initial 5 or indeed the 25 that will follow thereafter. I'm happy to take any questions that councillors may have in relation to either the report or any of the appendices that have been produced.
Thank you. Well, the first thing I'll say on behalf of the committee is well done. It's a very, very comprehensive piece of work. And so thank you for you and your team for doing it. And also, I think one of the things I picked up was this real emphasis of the voice, of actually listening to people. And I think that is come through a number of the strategies now. And that's the most important thing. We're here to serve the people of the islands, and it's their voice that we need to listen to and have. So I'm really pleased that that is really emphasised within that that report. Joe and then John.
Thank you. Do we know in very general terms sort of motivation behind these changes? What sort of led to them?
Adult social care has been subject to sector-led improvement for a number of years. That sector-led improvement has been carried out by the Local Government Association through peer review. During the pandemic, it's my view that the Department of Health and Social Care realised they had very limited sight in terms of what was going on in local authorities around adult social care. That limited view and equal limit of control in relation to those activities led to a rethink at the centre in terms of how ministers could be assured as to the quality of provision in adult social care in local authorities up and down the country. That led to the development of a number of discussions with a number of different interested groups, and as a result of that, a push for assurance has come forward. It's probably worth saying at this point in time, there's no decision as to whether local authorities will be rated as part of this process, and that's one of the key areas that's still outstanding. Pardon the pun in terms of rating language and describing this to you, but it's still left wanting in terms of the information available to us.
Thank you. John, you had a question?
It was just to say, Chairman, thank you to Laura for her clarity and her careful attention to detail.
Thank you. Any Joanne?
Thank you. I've just got a specific question in relation to the information section, and I know it's been raised before, but is the council looking at providing information to people that fund their own care so that they're aware of what happens once their funding reaches a certain critical level? And are the council prepared for the eventuality of taking over that funding? Thank you.
The local authority's got a statutory duty to ensure that we support people who fund their own care, as well as people for whom the local authority makes a financial contribution towards their care and support. We already have in place all of our policy guidance in relation to that. Our finance and charging officers are fully skilled in terms of not only assessing the person for an adult social care contribution, but also supporting them to access other sources of funding that may be available to them and advising them in terms of the future funding for their care and support. Our website contains comprehensive information in terms of that transition from funding your own care and support to being funded by the local authority, and information is also available through our frontline social work team. So I am 100% satisfied that that information is in place, that people, regardless of their funding source, are supported and will continue to be supported by the services that I'm responsible for.
Thank you very much, Laura, for a very comprehensive report and on answering questions. So thank you. I'll now move on to item 11, which is proposals to vary, develop or consult upon service changes. as stated, we got down here patient transport. That is on our September meeting, which is obviously a big issue that we obviously with the partners, and actually a big issue in discussion with these new changes of not just the finance of people moving, but actually the experience of going over the ferry, right? And not being in your car, and the lift not being big enough for a wheelchair, and these kinds of things. So we do need to I think dig deep a little bit about on those issues. We've obviously got dentistry on the next meeting. Is there anything that people want to update about pharmacy recruitment and retention challenges, or do we put that to the next meeting? Right. Okay. Can you bring back some things on that within that? And obviously, we have got the ongoing discussion about primary care and surgeries within that. Is there anything else that people wish to in this?
Chairman, it's just this thing about transport. It's been rattling around for years, and it would be nice to at last see some meaningful progress on it. When I say meaningful progress that translates down to the ground. I had an email only the other week from a guy who has a spinal injury, extremely painful, is double incontinent, booked on his ferry well in advance to give them notice that he couldn't get out of his vehicle, yet the captain decided that he ought to get out of his vehicle, and when he tried to speak to the person who was letting the vehicles onto the ferry, they turned his back on him, pulled the gate up and sailed off. And that's the sort of thing that we need to bring to their attention. It's disgraceful.
Michelle, Dr. Legg.
Can I just clarify for the agenda item update on primary care surgery loading, what particularly you would like to be updated on, what that actually means?
I think you wanted the GP surgery loading to be added to the agenda.
Oh, the work. Yeah, it was the workloads, to see how we're progressing with workloads.
Workloads, yep,
Yes.
Absolutely, can do that.
And how they're coping with the workloads, because as you know, Michelle, a lot of GP surgeries are actually private businesses, and there's not a bit of discrepancy between the level of service provided between one surgery and another. Okay. So it was to see commonality, but across the board.
We can do that. Just clarify that we're self-employed, but we actually hold an NHS contract, so we're not really private businesses. As in that,
clarification on that would also be appreciated. Thank
fantastic. You. Happy to bring GP workload on in September.
Anything else on that? We now go to item 12, work plan. If we look at the, as I've mentioned before, putting dementia on there, dementia strategy. But I think most other things are here. I am going to have a look at the work plan and see if we can perhaps bring it down a bit and actually focus very much on the particular issues, particularly that are concerned from the population, from people. I think that of side, because I think there's one or two things on this that are important, but perhaps not priorities for actual people directly. Is there anything else that anyone want to put regarding the work plan? No. We now come on to members' questions. Do any members have some questions? Nicholson, you can now do it much more.
Oh dear, yeah, the thorny issue of sharks. This is a problem. This is an issue that's been kicking around for years, and it is absolutely ridiculous. And if the integrated care partnership can't resolve such a simple issue as the collection of sharks, I don't think there's any hope for anything greater. So we've got a situation where people, for various reasons, have to use sharp instruments, medical instruments. They can collect from their pharmacy, I believe it's a 1 litre or a 2 litre yellow bin, specially to contain sharps. However, I'm informed that there are many people that need a far bigger bin. So a 5 litre bin, which they can get from their GP surgeries, I think I'm right in saying. One of my residents says he gets it from his GP service, but can he get somebody to collect it? No. You tell me. I can't get a straight answer.
Shall we look into that for you, Councillor?
Can we, if we can have a written response to that question, that'd be great.
Well, let's look into it and see exactly who collects it, where the contract lies, what the issue is with a 2 litre versus 5 litre collection box. But yes, can bring an update for. Would you like us to bring an update for September?
Or sooner, Michelle. I mean,
I'll write to you.
You should be able to solve it overnight, I would have thought.
Actually, we'd be
overnight.
I know that this issue's also been raised through Health Watch as well, hasn't it? So, any other questions? Councillor Lever, Joe.
Thank you, Chair. A bit left field, but it came up in the policing presentation today, and I've recently come back from Blackpool, where I was last week, and there was a big concern up there about a vaping epidemic, basically. Over 30% of children in Blackpool have used a vape or are regularly using a vape. I guess with it coming up in concern in the police presentation, and how wide-reaching the issue may be here, I guess it's a public health issue with GPs in some instances prescribing it as a way to come off smoking cigarettes. No, I've seen reports of that happen. Not specifically in Wight, but that has happened elsewhere. And then also the issue of the uptake with children casually using vape. How concerned are we about it on the Isle of Wight as an issue?
I really value your question, actually, because I think it's a really valid point. NICE guidance suggests that you can use vaping to support giving up smoking. And under those circumstances, it's more beneficial to do that. Smoking cessation is commissioned and delivered by Public Health on the island. So whether they are prescribing vaping materials for that, I couldn't tell you, but I imagine that Simon Bryant would be the chap to answer that. But your second point is the vaping directed for children with flavours and colours and things like that. And I'm not aware of how much it is a problem on the island, but considering that it's recognised as a problem nationally, I wouldn't be surprised if it's a problem on the island. But I think that actually has to be national guidance, because actually what they need to do is say it's illegal to sell vaping material to, say, somebody under 16, and also then to start directing communications and, education to people that actually vaping is not good under those circumstances to start vaping. But you see it more and more now. So, but I do think within a year or so there will be absolutely some legislation on this, because it is not healthy. Thank you.
Just wanted to follow up on Joe's thing, and I was going to ask the cabinet member, Ian, do you think that this issue, bearing in mind the vapes that were reported on the news had heavy metals in them, so toxic substances, is this an issue that should be discussed at some other board level, involving police maybe?
Stephen.
Thank you very much. I think most certainly that it should go forward and it should go through to community safety partnership area of the cabinet, and I think that's Councillor Lucioni who should be taking that forward. She's already secured disposal of the vapes, etc., through Iron Waste and what have you. And I think quite honestly, that's the way we should move it. And through informal cabinet, I'll take that forward from here, and we'll get something moved on the agenda. Okay.
Just in addition to that, Councillor Stevens, there's a public health involvement in this issue, right? And I think it's part of the fact that vapes have been recommended through public health. So I think it'd be good if there could be a crossover with your role as responsible for public health and Councillor Lucioni's regarding community safety. I think a lot of health issues now do cross over to other areas, whether it's policing. So for instance, mental health, that links into the police with section 136, etc. So I think one of the things I'm quite keen on the committee in the future is that we talk cross cabinet members and cross committees, etc., to make sure that these subjects don't get fallen through the gap, really. Right?
Totally agree with you, Chairman. I would say that we don't just meet in formal cabinet, we do meet informally, and there is discussion around cross-cutting issues. But we also speak with, as you know, across chamber. So it's great that we can discuss things and move them forward in the appropriate manner. I'll take it on board what you said, and I think it's very appropriate. And we'll come forward with a future way forward, and not leaving it too much in the future, because it's extremely important. But what I would do is also avail the services of Simon Bryant as well and his team. Thank you.
Dr. Legg.
I just think for accuracy of what we're discussing, vaping is only prescribed in a very limited area, and that is when you're trying to give up smoking, and it's certainly not advised prescribed in general terms. I think that's probably quite important that we make that distinction.
Sorry, Laura.
Chairman, with your agreement, I'd propose that I take Councillor Lever's questions back to Simon Bryant. I did agree to feed back to him anything that happened after he had to leave. So I can ask him specifically to provide the committee with a written response relating to whether children are being prescribed vapes to stop smoking here on the island, and to ask him to clarify how much of an issue children vaping is locally, if that would be useful to the committee.
And I think the health issues within that, because there's been quite a lot in the press about the mixture of the sort of reportedly child-friendly vapes, right, within that. So I'll have to get used to it. Any other questions? Sorry, Joanna, you had one.
Thank you, Chair. I've just got one question for the Trust. I wonder whether the Trust could provide an update to committee members and also to the general public about the future of Well Awards, just because there's been such public interest in this. And I understand the ward's been moved on a temporary basis, but it would be really great to have an update on the future of the ward, just to reassure the public. And given the fact that it's an outstanding and nationally recognised service, and one which the public greatly value, so if there could be an update on that, that would be really great. Thank you.
Nikki, you seem to turn on your immediately. the Wellow ward was mentioned, so I presume you can answer that.
I'm happy to, Chair. And just to say, Joanna's absolutely right. We have moved Wellow Ward temporarily, and we have relocated it while we undertake some other work in what was the Wellow footprint, and that's essential building works also to expand that area. We're undertaking at the moment a options appraisal just to find the best place to locate Wellow in the future as a sort of more permanent home. We have to bear in mind the context of our challenges as a hospital at the moment in our acute bed capacity. So some of that work that we're doing on the existing Wellow footprint is essential to create more capacity going forward. So I'm happy to bring a further update, a future HOSC as well, once we've undertaken the options appraisal, or to brief Joanna separately if that helps as we move forward in that space.
Thank you. I do know that on the agenda in September, the issue of comms and communications is on there, because I think one of the issues with the Wellow ward was it was staff members that were communicating to families and things that they thought that the ward was sort of closing. And I think it's just important that on the island, something comes out this, it goes like wild on social media the minute it's actually spoken, and therefore we need to get the comms out, because for at least 48 hours, there were a lot of very distressed people, including your staff, right? And including the pastor, who particularly, I think, communicated to others. So I think there's some lessons learned about communications, but it is on the agenda at the next meeting, so we can actually talk a lot about how we improve communications. So thank you. I will now actually, I'll do this, close the meeting.